Hello all, welcome to PharmaNandan. In this video we are going to discuss diuretic part 2. Part 1 is discussed in earlier video. Well, in this part 2 video we are going to discuss loop diuretics. Okay, in the part 1 we discussed carbonic anhydrase enzyme inhibitors, right? Here we are going to start loop diuretics. So what are the loop diuretics examples? Number 1, very most common drug furosemide, also called furosemide. Okay, it is also called as Lasix. Why it is also called as Lasix? We all know because it lasts for 6 hours. That is the reason trade name it is popular with the name Lasix. Okay, then what are the other drugs, popular drugs? Torsemide, we can see torsemide in tablet form. Okay, and bumetanide and ethacrynic acid. Okay, before discussing these things, let us draw the normal kidney structure in a schematic way. Okay, not for theory exam purpose, only for our understanding. This is the schematic diagram and we can see loop of Henle here, right? So the drugs which are acting in the loop of Henle, we call them as loop diuretics. Okay, and before discussing loop diuretics, we need to understand a chemical important point which is frequently asked in exams. That is this furosemide, torsemide, bumetanide. These three drugs has a common thing between these three things. These three are sulfonamide derivatives. And this ethacrynic acid is, it is not sulfonamide derivative. This ethacrynic acid is phenoxyacetic acid derivative. Then why we should know about this thing? Because these three are sulfonamide derivative, right? If a patient is having any irritability or allergic reaction to a propensity of allergy to the sulfonamide compounds, then furosemide or torsemide or bumetanide, these may cause some reaction in those patients. So in a patient who is a known case of sulfa allergy, these three drugs can be avoided. Then if I want to give loop diuretics, then we have to choose ethacrynic acid because it is not sulfonamide derivative. Clear? This is a uh, popular MCQ in exams, in competitive exams. Now let us start what exactly is happening in this loop diuretics. Okay, before giving pharmacotherapy, we have to know the physiology, right? So the as per physiology, so there is a channel called sodium, potassium, and 2 chloride ions importer. Okay, all these go through this channel in the loop of Henle during physiology for reabsorption. So this is a site of reabsorption of one sodium, one potassium ion, and 2 chloride ions. Through this channel, we call it as reabsorption. What happens when these loop diuretics are given? Let us say this furosemide or torsemide or any loop diuretics when given, these loop diuretics reach the luminal side of the nephron. Okay, it reaches the luminal side and then it blocks the channel sodium, potassium and chloride importer. It blocks this channel. So these drugs will block this channel from the luminal side. Okay, when it blocks from the luminal side, what are the things which we can anticipate now? So there will be no movement of, very less movement of sodium, potassium and chloride ions. So they are blocked, right? So it keeps on moving to the DCT. They keep on concentrating into the DCT and they reach the collecting duct tubule and then reach the urine. Sodium will be reached, potassium will be there and chlorine will be also be excreted. So loop diuretics excrete sodium, chlorine, potassium, obviously water also along with these electrolytes, right? But here one thing also happens along with the sodium, chlorine, sodium, potassium and 2 chlorides importer. Here actually for our understanding I have drawn a single line, right? In fact this is a two cell layered membrane. Okay, in the luminal side also the nephron it has one cell, right? So first these have to pass through this one. During physiology, when this sodium and potassium and chlorine ions are reabsorbed, there will be a small leakage of potassium also into here, so that it increases the positive energy inside the lumen, and so that this positive energy repels the existing other ions like magnesium and calcium back into the blood vessel. Okay, this is a normal physiology. Okay, here no one is there no one is there to inhibit this potassium leakage, right? Because we are blocking this channel, no leakage of potassium, so there will be no extra positive charge created in this here, so there will be no pushing of this calcium or magnesium channels from this side. Thereby the calcium and magnesium, which usually passes through paracellular transport during physiology, which passes through paracellular transport, this calcium and magnesium here, because I blocked this one, because with the loop diuretics drugs are blocking this channel, there will be no extra positive ion creation here, so there will be no positive ion charge generated here, there will be no repelling of calcium and magnesium from here. So finding no way, what happens to calcium and magnesium, they also keep on traveling through all the nephron and it reaches the urine. Calcium and magnesium will also be lost. Okay, so loop diuretics are losing calcium. Okay, this point we have to remember. Very popular mnemonic, loop loses calcium. Through the process, one more thing happens. Loops are very aggressive in diuresis. Okay, well, there will be sudden and loss of water from the body. Okay, so in hospitals we see when a person is given loop diuretics, so the urine bags fills very faster, right? So the patient lands in loss of blood volume. Okay, this will be the blood volume. The patient may lose in blood volume. Okay, blood volume will be slightly lost. Okay, but there will be no effect on bicarbonate inside the blood. Okay, only water is lost, bicarbonate ions are the same in the blood, relatively bicarbonate ion concentration will be increased, so we call it as condition of alkalosis, which is happening in the blood. Okay, and all this thing is happening inside the kidney. So whenever anything happens inside the kidney with respect to alkalosis or acidosis, we call metabolic. Here we can see alkalosis, right? So metabolic alkalosis is one of the side effect which we see through the usage of loop diuretics. Well, coming to the uses of loop diuretics, when should I use loop diuretics? Uses. Actually, there are many uses. Okay, to make it short, we are discussing only 9 of the uses which we see routinely in hospitals. Okay, 9 uses. So the very first thing which we should remember is loop diuretics are recommended for if in any situation where we want any quick diuresis or vigorous diuresis. Okay, like we can say in acute pulmonary edema. Okay, in hospital in emergency when we see acute pulmonary edema, in even in ICU also, immediately we give loop diuretics, usually furosemide injection for acute pulmonary edema. And the second use is when there is chronic congestive heart failure, we give diuretics, right? We give this loop diuretics. And the third use is in hypertension. In this hypertension also, we have to remember two things, two situations. Whenever a person is diagnosed as hypertensive, we will check the kidney status. Okay, right? When if the kidney is normal, okay, if the kidney is normal in that patient, then what is the thing which we recommend to the patient? Yes, thiazides, not loop diuretics. When kidney is normal, thiazides become the first preferred drug. Okay, first preferred drug of choice. But if we notice the kidney is physiologically a bit compromised, that is, we will see some age-related decrease in GFR. Okay, then hero will be loop diuretics. Then loop diuretics will come to play. These become the first choice of drug. Okay, first preferred choice, first preferred drug of choice. And the next use is massive edema. When do we see massive edema in a patient? Yes, massive edema. Underline the word massive edema. Okay, when we see this condition due to CKD. Okay, but here the thing which we should remember is loop diuretics are given in high doses. Okay, usually Lasix, this furosemide will be 40 mg, right? They will increase the dose up to 60 or 70 or 80 also, depending upon the edema. So to relieve the edema. Okay, and there is one more situation where we treat edema in another patient. during ascites. Where do we see these things? Yes, in liver cirrhosis, or even if a person is landed in nephrotic syndrome also, we will see this edema and ascites. Then we will give loop diuretics. And one more thing is, sixth one is loop diuretics we combine with 3% NaCl. 3% NaCl in a special condition when there is any life threatening hyponatremia, then we give 3% NaCl to replenish the last sodium ions. Okay, so when we are trying to replenish last sodium ions, we have to pull out the excess water also. So we give 3% NaCl along with loop diuretic as a combination, that to treat life threatening hyponatremia. The remaining three uses are, yes, I told you, loop loses calcium, right? So it is indicated in hypercalcemia, indicated in hyperkalemia, and it is also indicated in intoxication of any bromide or iodine or fluoride poisoning. Okay, accidental poisoning cases. And there are 6 side effects which we should remember. 6 side effects. For side effects, first thing we should remember, we can recall about any diuretic is usually loss of electrolytes. It is very aggressive for loop diuretics. Okay, so the most common side effect will be loss of electrolytes, disturbance in electrolytes. So what we see is, most common thing we see is hypokalemia, most common side effect. Okay, the second side effect which we need to remember is, it increases the GRBS levels in the blood. Okay, but it doesn't mean that it is not contraindicated in diabetes mellitus. It doesn't mean that if a patient is having diabetes mellitus, we should not think that this drug is contraindicated in them. Yes, we can happily give loop diuretic them. It slightly increases GRBS levels, which we can easily manage. The third side effect is, it causes dyslipidemia. That is these triglycerides, LDL levels, all this together, we see there will be a dyslipidemia condition due to prolonged therapy of these loop diuretics. Okay, and the next side effect is erectile dysfunction, and in some cases we can see hepatic coma also. And for competitive exams, very popular MCQ asked is ototoxicity. For ethacrynic acid, we see this ototoxicity when we give any rapid IV administration of this injection, ethacrynic acid, but in patients with pre-existing hearing impairment already in with them. So the clinical feature of ototoxicity will be, the patient will complain of tinnitus after using a loop diuretics. Then we have to consider it is ototoxicity due to the loop diuretics, maybe due to rapid IV administration, but the thing is there will be some pre-existing hearing impairment in the patient, that we have to keep in mind. Yes, by now we covered some must to know points about the mechanism of action of loop diuretics and most common uses, and 9 uses we studied and 6 side effects, right? But there are some points which are nice to know regarding loop diuretics, which are often fascinating and they are asked in competitive exams. Okay, so what are those nice to know points? First thing is bumetanide. About this bumetanide, it is a highly potent molecule. Okay, so they will ask you which is highly potent. Bumetanide, it is highly potent molecule. Okay, and the fact number 2 is about furosemide drug. This furosemide has a property of, it decreases free water clearance. And the fact number 3 which we should remember is, the point is, when in anuria patients, the patient could not pass urine, right? So he could not empty the bladder, then we give loop diuretics, okay, as a trial dose. Okay, we give loop diuretics as a trial dose. If this trial dose is not responsive, so what is the next line in the options? there will be an option stop this loop diuretic. And we should not go for the option increase the dose of loop diuretics. It will be wrong. Okay, the correct answer will be stop the loop diuretics. Okay, when there is unresponsive to the trial dose of loop diuretics in a patient with anuria. Okay, and the other thing is regarding uric acid. For the uric acid, most commonly we see it decreases the excretion of uric acid, so that uric acid will be pooled more and more in the blood, so it is not so recommended in gout patient. That is, this is contraindicated in the gout patients. Okay, but this happens during chronic usage. During acute administration, reverse happens. In acute administration of loop diuretics, usually uric acid excretion will be increased. But during chronic administration, the uric acid excretion will be decreased. Okay, so when uric acid excretion is decreased, it keeps on increasing the blood, so it causes hyperuricemia, but not up to painful episodes of gout. Okay, we see hyperuricemia without gout episode, we call it as asymptomatic hyperuricemia when used chronically, when used on long-term basis, chronic usage. And the last but not least, the property of the loop diuretics which we should remember, which is useful in clinical practice, is this loop diuretics has a property of it releases prostaglandins in the kidney. Okay, in kidney, which leads to vasodilation of afferent arterioles in the kidney. Okay, so when afferent arterioles are vasodilation are dilated, we see there will be more GFR. Okay, more the GFR, more the loop diuretic will reach the lumen of the nephron, so it acts efficiently. Okay, but when I combine loop diuretics with the NSAIDs, what is the property of NSAIDs? Yes, we know, right? So it decreases the prostaglandin secretion. Okay, so there will be no less vasodilation of afferent arterioles. There will be relative decrease in the GFR. So relatively very less amount of drug reaches the site of action, that is lumen of the loop of Henle, thereby resulting in the decreasing in the efficacy of loop diuretics. Efficacy of loop diuretics are decreased when they are used concomitantly along with NSAIDs. This is one important property which is used clinically. And one more important point for competitive exams is with respect to this Bartter syndrome. Okay, BRTTER Bartter syndrome. What happens in this Bartter syndrome is there will be some mutation. Due to mutation in the Bartter syndrome patient, okay, it's a genetic disorder, and this due to this mutation, what happens is there will be a natural condition in the property in the body, as if there is some natural diuretic already working, as if natural loop diuretic, if it is working in the body, how it works, this is the thing which we see in Bartter syndrome. Okay, naturally diuretic effect without giving any diuretic effect. So what happens to the patient? Naturally, without any diuretic also, patient will keep on losing all these electrolytes. Okay, sodium, chlorine, potassium, all these things. Okay, but for this Bartter syndrome patient, knowingly or unknowingly, if we give this bumetanide or any loop diuretic, bumetanide or any loop diuretic, what happens? It will worsen the loss of potassium. It keeps on losing the more and more potassium in the urine. Okay, so there will be very very less potassium in the blood. So we see hypokalemic condition. Already the patient has a propensity to land in hypokalemic condition. Okay, but if we give any loop diuretics to a Bartter syndrome patient, this hypokalemia worsens, worsening of hypokalemic. Already the patient is landed in metabolic alkalosis, because natural loop diuretic effect is ongoing in the patient with Bartter syndrome, right? So if we give any loop diuretic in a Bartter syndrome patient, it worsens the hypokalemic metabolic alkalosis. This point is useful in clinical practice, and it is very popular MCQ in exams, entrance exams. So as of now, we discussed the main must to know points about mechanism of action, uses and side effects, and there are some nice to know points which we discussed. These points are useful in competitive exams, even in clinical practice also. So by now we can conclude the discussion on loop diuretics. This is the part 2 of diuretics. Part 2 of diuretics is loop diuretics, which is acting in the second part of the nephron, that is loop of Henle. Okay, then, well, thank you for watching, and if you have any queries, please feel free to post it in comments, and I will read each and every comment. Thank you. Thanks a lot.